On Friday's general session, we're going to present the data from the alternate trial. So alternate is a neoadjuvant endocrine therapy trial in postmenopausal women with clinical stage 2 or 3, estrogen receptor rich and HER2 negative breast cancer. So patients in this trial, they were randomized to get fulvestrant or anastrozole or the combination for 6 months before surgery. What happened is there's a required biopsy at baseline and also at 4 weeks on treatment. So if a patient has a Ki67 over 10% on treatment at 4 weeks, then they will be triaged to receive chemotherapy, since elevated Ki67 on treatment means that they're not responding to the endocrine therapy appropriately. So in this presentation, we are reporting out how they responded to the neoadjuvant chemotherapy. So over 200 patients from the alternate trial were triaged to receive neoadjuvant chemotherapy because of the high Ki67 on treatment. And eventually, over 150 patients received neoadjuvant chemotherapy. About 80% of the patients were able to complete their neoadjuvant treatment as planned. And then at the time of surgery, we looked at pathologic responses, including the residual cancer burden. So this is a way to estimate how much cancer is still there based on the tumor cellularities and lymph node status. So based on the results, what we were going to show is the pathologic complete response rate is fairly low, close to 5% overall. And majority of the patients still had significant amount of residual disease when we use the MD Anderson RCB burden to calculate, they're in the categories 2 and 3. This is important because these patients already have shown to have resistance to endocrine therapy, and now they are also not responding to chemotherapy well. So patients with RCBs 2 and 3 in previous studies have shown they're correlated with the worse outcome for these patients. So what we're doing now is trying to understand the molecular mechanisms. What mechanisms are driving these cancers, so better treatment could be developed.